Good evening, Dr. Christensen. I'm super excited to have you on the podcast. So welcome.
Well, thank you for having me.
So what you were just telling me what did you run? What did you do yesterday? Run or bike? I forget which one.
Actually this morning I did a 67-mile bike ride.
Oh, that was this morning. Yeah, you're
Yeah.
still doing this podcast with me.
Oh, yeah.
Oh man, you're dedicated. Well, again, thank you so much for taking the time to come on. If you want to start out by telling the listeners about yourself, your background, and how you got into airway.
All righty. Oh gosh. I'm a 30-year veteran in the world of dentistry, which makes me feel old, but just had a heart procedure here about 2 months ago, which revived me, and now I'm feeling about 20 years younger. But went to dental school clear back in 1989, and while I was in dental school, got into the military, and ended up being a practice in general dentistry for 4 years in Germany, and did a lot of surgery while I was there. And then while I was doing all the surgery and stuff, I had one chance to go once a month to a orthodontist in Germany and work with him for a day. And that's when I decided I had to become an orthodontist. So went to orthodontic school, and then I had to give the military back. Did 8 years in the Army, which was it was that tipping point. Going to be in the military for the career or get out, and I decided to get out, and came to Lewiston, Idaho, which is a little town up in the kind of the panhandle of northern Idaho, and set up my practice on my own, and went to doing the orthodontics like I was taught in orthodontic school. And as I was treating my patients, we were trained to do expansion on kids that have a crossbite. And so, but I also got my master's degree in treating kids with an underbite and face mask protraction. And so there was 2 classes of patients that I would treat that had maxillary deficiency in the transverse and the AP dimension. And when I expanded these patients, I would have parents come back to me and say, wow, ever since you expanded my kid, they are doing better in school. My kid stopped snoring, and my kid is better behaved. And even some of them would come back and say, hey, we were on the verge of putting my kid on ADD medicine and ADHD medicine. And I just kind of blew it off and thought, well, okay, that's cool. I have no idea what I did. But one of the things that happened during that process is when I expanded these kids, a lot of them had crooked and crowded teeth. And I figured out that I didn't have to take out teeth. And so about 5 years into my practice, I started expanding more kids rather than taking out teeth. And I'd taken out a lot of teeth on patients. Sorry to say, but I've got some of those patients back now as adults as sleep patients. And I wish I never would have pulled teeth on them, because there's really no need for it. But anyway, so it was when I decided to do expansion instead of extraction, the parents came back more often, and it seemed like it was almost on a daily basis of, wow, you helped my kid to sleep better. And and so I just kind of slowly progressed through that. In 2012, I had a massive heart attack. Actually wasn't supposed to live, according to the cardiologist. I had the widowmaker, and kind of stepping back a few years before that, my first adult sleep patient was my father. And he was at my house one day, and he always went and took a nap, and I never really paid attention to it. But while he was in taking a nap, I heard this god-awful sound. And I went in there and I sat down and watched him, and I thought he was going to die right there on my couch. And he stopped breathing, and I would sit there and I'd recording him on my watch and go, oh my gosh, he stopped breathing there for 45 seconds or a minute.
Wow.
And so I woke him up and I said, you have what's called sleep apnea. I brought him down to my office, and I made the first jerry-rigged sleep appliance that I could make, anything that I could do to just hold his bottom jaw forward. And I said, we've got to get your tongue out of the back of your throat or else you're going to die. And his mother actually passed away in her 60s, I think, with dementia. And I remember being a 7-year-old when she died. And I remember that anytime we went to their house, I never slept because even though she didn't sleep in the same room, she made so much noise that I never got any sleep while I was there. And they lived in a log cabin. So it was, so anyway, after treating him, I had other patients that said, hey, do you know how to do a sleep apnea? So I kept making these little jerry-rigged appliances. And in the process of that, I got to the point where I was starting to get 2 or 3 patients a month, and I treated them for like $300-400 to make this appliance, just because I didn't realize that, you know, I mean, they all said it really helped, but I mean, I was totally guessing. And I was guessing where I was putting the jaw, guessing what I was doing. And I said, I don't know if this is going to work, but I know it worked on my dad, and people were just happy. Anyway, after my heart attack, that first year after my heart attack, I told my wife, I said, we've got to get trained on this stuff. We've got so many patients. And I says, I'm not really qualified to treat people. And so I went to my first Sleep Group Solutions meeting over in Seattle. And while I'm in this meeting, they've got this cool machine. It's called a rhinometer and a pharyngometer. And they spent a lot of time on the pharyngometer on how to use this to position the jaw, so you know where to place the mandible in the vertical and the horizontal position and everything. And they kind of breezed over the nasal portion, the rhinometer part of it. And I'm sitting there thinking, okay, I've been doing expansion with all these kids and I know that they're breathing better, but I have no way of measuring it. And so I asked them, I raised my hand, and John hates me using his, John Nadio, I don't know how to say his last name, just John from Sleep Group. Anyway, I raised my hand, and I'm the only orthodontist in hardly any of these sleep meetings that I ever go to. And I said, can you use this rhinometer on kids? I said, I want to know if what I'm doing with expansion is actually making a difference. And he said, well, this is used to tell if you need to send an adult to the ENT. You know, if they can't breathe through their nose, it doesn't matter. If you can't breathe through your nose, you can't help correct people with sleep apnea. And I said, but can you use it on kids? And he says, we don't know. We've never done it. And so back then I think it was like $30,000 or something for that and the training for them to come to the office. And we ended up getting the rhinometer and pharyngometer, and they came and trained us. And at that point in time, in probably 2012, 2013, I said, all right, every single patient that walks through the door, we're going to get a baseline on them. And then we're going to measure the little kids after we do expansion to see what happened to their nasal airways. And so I've got data from 2013 to 2022.
Wow.
And I didn't know what to do with the data. I just kept collecting data because I figured that someday somebody would want to know what we're doing.
I didn't realize you were doing it since 2012.
Yeah. Well, I mean, actually, my heart attack was December of 2012. It wasn't until 2013 because.
But still, essentially almost a decade. I mean, that's amazing.
Right. We got thousands of patients in our database. And but what we found is that when you expand a little kid with an expander, you have an 8mm expander, you get about 5 millimeters of skeletal growth, and you get about 1.5 millimeters or 3 millimeters of dental tipping. And it's just common that's what you're going to get. And so you get 4 or 5 millimeters of actual skeletal growth in the nasal passage. And calculating the data on that, we found that the minimum cross-sectional area, which is really close to the nasal valve, we got around 40 to 42%, I think, is what the increase in the nasal cross-sectional area is. And some patients we had 100%, 200%, some patients you have 10. But, we just kind of did a straw poll of this and said, okay, how much do we get on that? And then on the volumetric change, we get around 60% improvement on the nasal volume. And then what's really interesting by having this data and looking at every patient, like I had a patient here last Friday, we did an in-office course where we had an orthodontist and a dentist come, one from Delaware. If Joanna Green ever seen this, hi Joanna, she was awesome. And then Daniel Dalen, he's a brand new orthodontist, not even a year out of school, learning airways. And
Where's he located?
he's down in St. George, and this guy right here is going to be a rock star. I mean, brand new. He's got so many more years to do this than.
Wow.
He's already sent me a case. He sent me a case today and said, "Hey, what do you think about this?" And a little kid that's I think three or 4 years old that is still bedwetting, snoring, breathing through their mouth, and all the different things. But anyway, we. Where was I at on this?
That they came into the office.
Yeah. So anyway, we look at these. We had a patient that was in here, and one nasal airway was low, and the other one was low but not as bad.
Mm-hmm.
I told them, I said before we went and retested, and this is a kid that we retested, I think only just 2 months after expansion. Mm-hmm. And I said, this is what I said. I don't know what's going to happen when we test him, but normally what you're going to see is you're going to see a patient that has a low nasal airway on one side. And then when you expand him, the side that was low is going to leapfrog the side that is better. Mm-hmm. And so we did the testing, came back, and that exactly what happened. It's almost like the body says, I have been needing this for a long time. And now that you developed everything, I'm going to just take all of this development and put it towards the side that I can't breathe through. Mm-hmm. And so the side that was, I think he had a 5 millimeter cross sectional and on the good side, and it was like a 2 millimeter cross sectional on the bad side, and it jumped up to like better than the 5. And for this kid's age, that put him right at normal. And so now, and I asked the parents, I said, so how is your kid doing? And they said, all the symptoms are gone. Our kid is sleeping through the night.
And this is just transverse expansion.
Right. It's just a simple expander. I use the Hyrax expander on the regular kids. And then we designed what we call the Everly expander. And the Everly expander, the reason we call it that is my granddaughter was my first 3-year-old that I ever treated. And she had, and this was, she's now 6, and we treated her when she was 3, so 3 years ago.
Wow.
We were actually at a tongue tie course, and my daughter messages, says, you got to do, Dad, I know you're doing stuff with airways, and you've been treating all these kids at 7 and 8 years old. He says, is there any way for you to treat Everly? And so we came back and we used the fixed lingual expansion appliance, the little small expander that we use on the lower jaw from the older kids. And we use that on the 3-year-olds. So because it's so much smaller and it won't be intrusive to the tongue. And we put that in there. And her symptoms were bedwetting, night terrors, just mental meltdowns. Mm-hmm. She would wake up 7 times a night. And her parents, from the time she was born, never got a good night's sleep. I remember her falling asleep in her food. We went out to eat one time, and they said she just would just collapse. And a month into the expansion, no more night terrors, breathing through her mouth.
And that was you said the lower expander, fixed expander you use in the older kids, you used on the upper because it's smaller.
Yeah.
Gotcha.
Right. Yeah, God, I wish I should have grabbed, I've got models of this stuff. Do you mind if I run and grab them real quick?
Yeah, of course.
Go ahead. A little bit of thing. You can talk to everybody well.
All right.
Hey, we're back.
We're back.
So Okay, so I'm going to show you the different expanders that I use on the kids that are, above 7 years old. And so this right here is a regular, just a high rack expander. We put bands on the first bicuspids and the 6-year molars. And what I found is I end up now that I'm looking at airways pretty much exclusively when patients come in, and people are coming to me from all parts of the country now for me to help their kids and stuff. But anyway, so this is what we use on the, above 7-year-olds. And then this right here is a lower expander. And what we end up doing with the lower expander is this, going back to the upper, we do 1 turn a day on this one for about 32 days. Each turn is 1/4 millimeter, so you get about 8 millimeters. And so this one right here, you're getting an orthopedic effect where you're splitting the suture and you're actually just expanding that bone. Now we don't have a suture on the bottom, so we got to go a lot slower. And so what the lower, this is called a fixed lingual expansion appliance, or we just call it a flea. This one right here, we go 1 turn every 3 days or about twice a week. And that takes us about 3 months. And so you can see that the design of that one is a lot smaller.
Yep.
And so what we ended up doing is, we don't have a pediatric model, but what we ended up doing is going in and taking that upper one and making it fit on the, or taking the lower expander and putting it on the upper. Initially, we just put it on 2 of the primary teeth, or 1 of the primary teeth on each side. And then we noticed these little kids were popping it out. And so we put it on the D's and the E's. And then what that does is it gets us a lot more stability.
Mm-hmm.
And then we do the 1 turn a day for 32 days. And you just sit and watch those little kids, their jaws expand. And usually what we do with the little kids that are 3 to 5, 6 years old, we do the upper expander, the Everly expander on them. And then most of them are so transverse deficient that they will need 2 of them. And so by the time they get to about 6 or 7 years old, then what we do is we go to the regular expander and the flea to get both of them to grow together. A lot of the little kids that you expand at 3 years old, you do the expander on them, and their bottom arch, which is dumped in there trying to fit underneath that small upper arch, over time, it automatically just comes out and matches up. I have 3 grandsons that are 4 years old that we've already expanded twice. And what's cool about them, we started them at 3 and we did an upper expander on them first, but at 4 years old, they were still having some airway issues. And so we went and put a second Everly expander in there, and we put a flea on the bottom just to keep things going. Mm-hmm. And so now I've got a pool of a whole bunch of little kids that even 4 or 5 years old that have expanded twice. And what's cool is those guys, we're now looking, those patients at that age, we're looking at their dentition. They've got big spaces in there. And the other thing that's happened with these little 3 and 4 year olds is, Beckham, who's Everly's brother, mm-hmm. he actually was developing a underbite. Okay. And Everly was developing an overbite. Mm-hmm. And so I'll use my hands to show how that works and how their breathing compensations determine what their skeletal growth pattern is. So like with Everly, when she was little, she just dropped her bottom jaw and, breathed through her mouth this way. And with a little kid that's got an open mouth posture and their bottom jaw is dropped, what happens is they start to develop that class 2 jaw relationship. Because as their bottom jaw is just hanging here, it's not actually up here meeting with the maxilla, and so it doesn't have that stimulus to grow forward. It needs that function for it to grow forward. The other thing that happens with a lot of these little kids is because their bottom jaw is hanging here, their upper jaw, rather than growing forward, just starts to drop. And then you start seeing all these little kids that have gummy smiles. And just by going in on Everly and expanding her upper jaw, her mouth closed, and she's now class 1, whereas before she was a class 2. Now her little brother, when he was even 6 months old, without any teeth in there, he had an underbite. He was actually sitting, I remember the day I was sitting there holding him in church, and he would sit there sleeping with his lips parted, but his bottom jaw was forward. And I remember just going in and going, closing his lips, and it didn't take but just a couple of seconds, and all of a sudden he was panicking, and he was coming awake. And so Beckham, as he developed, I was like, oh, I'm going to have to use reverse pull headgear and bring his upper jaw forward and everything. And we put the first Everly expander in on him, and his upper jaw actually just came forward on its own. I didn't have to put the reverse pull. And so now that we've done 2 expanders on him, he's got tons of space in between his teeth, and he's got a perfect class 1 bite. And my hope is, now that he's got all of this space and he's breathing correctly and he's sleeping right, I'm hoping to never put braces on him. And that would be the ultimate best treatment, is you get these little kids jump started and get them back up to their correct growth and development stage. And once they're growing correctly and they're breathing correctly, then they should continue to develop. Now, the one thing that all of my grandkids have, they all have posterior tongue ties. And there's different trains of thought out there and everything on that. My oldest grandson, we've corrected his, but I kind of look at it, and this goes back to the myofunctional therapy of these kids happen to be able to function right with that tongue. And most 3 and 4-year-olds are not cognitively ready to follow directions. And so if I don't get a tongue tie corrected in the first year of life, and parents can help that tongue to heal correctly, I will usually wait until the parents say, this kid follows directions and is going to do the myofunctional therapy. And so my oldest grandson, Ridge, I mean, he was amazing at the myofunctional therapy. We sent him there. He worked with her for a couple of months on everything. And then when we released his tongue tie, he had incredible results. And he's got big spaces in his teeth now. And we only ended up doing one expander on that little guy. And I pray that we don't ever have to even put braces on him. Now it's a matter of making sure that if you can get that corrected earlier in life, then that tongue does its job. It's up there where it's supposed to be. It's helping the jaws to develop.
Now, why do you think, I mean, you're an orthodontist, so maybe you can answer this better than when I ask general dentists this question. Why is it so hard for some orthodontists to wrap their head around starting early?
I'll use the orthodontist who's in my practice. He just went through a 3-year residency. He's not been in practice for more than 9 months. And when he came here, he said, I am blown away. He says, they did not teach me one bit of this in orthodontic school. And going back to before I really went into airway and just, jumped into it, both feet, orthodontists are a proud group. We are specialists. And there's an attitude that general dentists don't know what they're doing. Unfortunately, I don't know if that's ingrained in our type A personalities. I have 2 orthodontists in my town that say I'm a heretic, that I'm a crackpot, that I don't know. And yet I have an orthodontist that lives 100 miles away that came to my practice that's in another town that said, oh my gosh, I've got to go home and do this. I think that when they start learning about this, you're either going to accept it and you're going to delve into it. But if you do, it is going to slow down your practice.
Mhm.
Because my and doing a model analysis and I'm doing referrals to myofunctional therapists and NTs and they're involved in treating a